Thanks for downloading and welcome to Take Orally, the podcast from Dream Queen's Medical Centre, Nottingham. This episode will be discussing emergency contraception. As ever, all information is correct at the time of recording. Any and all guidelines mentioned are correct for Nottingham University Hospital's NHS Trust. Other trust guidelines may vary. All views and opinions at the speaker's own. Hello, welcome back to Take Orally, and this is the third episode in our genitourinary medicine series. Once again, Dr. Katie Boog has joined us. Hello, Katie.
Hi.
Hello. And we are going to be discussing emergency contraception in this episode.
Yes.
Bread and butter stuff.
I hope so.
So when do junior doctors need to think about a patient needing emergency contraception?
Every woman that you see. So, well, that's what I would like everyone to do, but clearly this is my special area and I'm a bit obsessive about it. So no, any sexually active female who's either not on contraception or where you think contraception might have failed, try and remember to think about emergency contraception, because you might prevent an unplanned pregnancy. You might be the person that helps prevent that termination. So it's really important to try and remember and think about it all the time.
So when you say contraception might have failed, what do you mean by that?
Yeah, so sometimes people are on contraception but it's not working optimally or they've not used it. So they might be using condoms for contraception but either they've forgotten to use it or it's come off or it's split. If they're taking the pill, if they're taking the combined pill and they've missed 2 or more pills in a row, then the efficacy of that's going to drop, so they need to think about emergency contraception then. Or with the progesterone only pill, if they're more than 12 hours late for the desogestrel pill, which is the one that we tend to use, that's Serel, Cerazette, Fianola. They've got a 12-hour window to remember that. Or if they're on one of the older pills, then they've only got a 3-hour window to remember. So if they're late with their pills, yes, that's why we don't tend to use them very often, because 3 hours isn't very long to remember.
And my eyebrows went up then.
Yes.
You're going to see that on the podcast. I was like, wow, 3-hour window. Okay. Yep.
Yes, not long to remember. So late with their pills or missed pills. If they're on the depot injection, which we usually give every 3 months, if it's been more than 14 weeks since their last injection and they've had sex since then they might need emergency contraception. If they have an implant in but either they can't feel it and we're not sure it definitely is still there or in the right place, or if it's been in for more than 3 years and it's not going to be working as effectively as it should be, then you need to remember to think about it. Or if they have a coil in and either the coil is coming, so you might go to examine somebody and see that the coil is actually coming out, either with or without them realising, or if you examine them and see that there's no threads visible, although this often means that actually the threads have just been sucked up into the uterus, it can mean that it's come out. So in that case we need to assume that they've not got any ongoing contraception and give them emergency contraception. Or if they've been taking liver enzyme inducers, which affect all the methods of contraception apart from the injection and the coils, then they might need emergency contraception, and just remembering that that effect from the enzyme inducers lasts until 28 days after they've stopped taking it. So if they've had enzyme inducers within the last month, they might not realise that this has interacted with their their normal contraception.
So that could be like antibiotics in particular? Yeah,
so mainly the enzyme inducers that we think about are medications for HIV, TB and epilepsy, but also things like St John's wort as well, which some people might take over the counter, which interacts with almost
everything. Let's on everything, just don't take it.
I know.
Don't take St John's wort. And when you said 2 combined oral contraceptive pills in a row, do you mean 2 days in a row?
Yes. Yeah. So if you miss 1 day, then you're fine. Just take it, carry on as normal. But if you miss 2 days in a row, then that's when you would need to be thinking about using condoms for the next week, and you might need emergency contraception. And
what about if your patient's on some variety of pill and they have vomiting or diarrhea? Does that ever affect things?
Yeah, so if they have vomiting or diarrhea, then I advise them to act as though they're missing pills on those days, because it might not be absorbed properly. So if it's just 1 day, then that's fine, but if it's for 2 days or more, then they need to be thinking about using condoms and think about emergency contraception.
Okay. And if you have missed pills, how long is it, if you then start retaking as normal, how long is it until you're back and covered, as it were?
Yeah, so with the combined pill it would be 7 days before you're covered, and with the progesterone only pills it's 48 hours, so once you've taken 3 pills correctly in a row.
It's as though you didn't miss them.
Exactly, you're back covered again after that.
Cool. Okay, so we think our patient needs emergency contraception. What types of emergency contraception are there?
So we have 3. So we have 2 oral medications. So there's Ella ELA1, which is ulipristal acetate, and there's levonorgestrel, which is a progestogen, which is sometimes called Levonel. That's the common brand name for it. Or you have the copper coil. So they're your three different options for emergency contraception.
Okay. So how do they work?
So the oral ones work by delaying or preventing ovulation. So once you've had unprotected sex and you've got sperm inside the uterus, it can last for up to 7 days. Some books say 5 days, some say 7 days. So we'll go with 7 just to be cautious. Last up for 7 days. So what you're doing with the pills is delaying ovulation so that by the time you ovulate, that sperm has died off, and so you've not got any fertilization occurring. So that's how they work. With levonorgestrel, it doesn't work quite so well around the time of ovulation. So if we go back to our physiology, the LH levels at the start of the menstrual cycle are just petering along, and then just before ovulation you get a big surge in LH, and you ovulate when you get to the peak of that LH surge. So levonorgestrel works until that LH surge has started. ELA1 works until just before it peaks. So ELA1 works better mid-cycle when somebody is about to ovulate. And then the copper coil works differently though. That doesn't have any effect on ovulation. What that does is it prevents implantation. So it means that if sperm and egg have fertilised, then you're using the copper coil to prevent that blastocyst from implanting in the uterus.
And how does it stop it implanting?
So it affects the endometrium, so it makes it hostile.
Hostile
environment, so that it can't implant.
Wow, okay, excellent. And so how effective are they?
Well, with the oral methods, because they're working by delaying or preventing ovulation, they only work if you've not ovulated yet. So if you take them in the second half of the cycle when you've already ovulated, you might as well take a Smartie. So they're not effective, okay? Also, their effectiveness drops off as time goes on. So with levonorgestrel, it's licensed for 72 hours, but we can use it up to 120 hours, so up to 5 days afterwards. But in days 4 and 5, it's really not very effective. With ELA1, it is more effective right up until 5 days, but again, only if you've not ovulated yet.
Okay.
With the copper coil, it's more than 99% effective no matter where you are in the cycle. So that's why the correct answer if somebody's eligible for a copper coil is always that that's going to be the most effective method of emergency contraception.
So you've already mentioned there that you can use them at different times of the cycle. Can you go into a bit more detail about that?
So with levonorgestrel, it's licensed for 72 hours, but we do use it up to 120 hours, so up to 5 days afterwards. And that's the same for ELA1, but ELA1 is licensed for up to 5 days. With the copper coil, it's slightly different. So with the copper coil, as I said, what we're doing is we're preventing that fertilised egg from implanting. That's the purpose of it. And we know that after fertilisation, it takes more than 5 days for the embryo to implant. So with the copper coil, we can fit it either up to 5 days after the person's ovulated, if we know when they've ovulated, and we can talk about that in a minute, how we would work that out. Or we can fit it 5 days after the first unprotected sex they've had. Because if they've only had unprotected sex once in that cycle, we know that they can't have an implanted pregnancy until more than 5 days after that, because that's the earliest time fertilisation could have occurred. And if we know their cycle, then we know that they can't have fertilisation can't have occurred until they've ovulated, so we've then got 5 days from ovulation. So it's whichever occurs later, so 5 days after unprotected sex or 5 days after earliest date of ovulation.
So, and how are we going to know if our patient has ovulated? I'm sure we can't just ask them. Did you ovulate?
They might have an app and they might think they can tell you that may or may not be correct. So the way that we work that out is if they know their cycle length, then we take the length of their cycle and we minus 14 days.
Okay.
So the second part of the cycle is fixed at 14 days. So ovulation to first day of menses is always 14 days. It's the first part of the cycle that varies in length. So if somebody has a 28-day cycle, then that means they would ovulate day 14, because 28 minus 14 is 14. If they had a 32-day cycle, then they'd ovulate day 18, etc. If they have a variable cycle, which lots of people do, then we've got to err on the side of caution. So we go by the earliest potential date of ovulation, so we go by the shortest cycle. So if they sometimes have a cycle that's only 26 days, but the rest of the time it's 30 days, we'd have to go on 26 days. So 26 minus 14 would be 12.
Okay. Are those apps any good?
They're really helpful for me in clinic because people write down when they've had sex and when their periods are, and it's made my life a lot easier. In terms of using it as a method of contraception, not so much. They're definitely not as effective as the hormonal methods or the copper coil. But in terms of
is that those apps that say you have a 5% chance of pregnancy today or something like that?
Yes.
And, so this is a high risk day, this is a low risk day.
Exactly, yes. So I certainly wouldn't recommend them if you're really not wanting to get pregnant. If pregnancy is not that big a deal for you, but you're just trying to avoid it, then fine. But in terms of tracking periods and monitoring side effects and symptoms for PMS and things, the apps are good, and they're very, very helpful when people come into clinic because they can tell me exactly when their period was every day they've had sex in the last month. It's great.
So we're giving our patients a medication, or we're putting some instrumentation inside them. There's always side effects when we do things to our patients, so what do we need to warn them about?
So with the oral methods, really the main side effect is that sometimes it can cause nausea or vomiting, and if they were to be sick within about 2 hours of taking it, then it might not have had a chance to work, so advise them to come back again. The other sort of common side effect is some irregular bleeding or spotting, either around the time that they take it, or their next period might be slightly early or slightly late. And we do always advise people, though, after emergency contraception to do a pregnancy test 3 weeks later, even if they have had a bleed, or even if their bleed comes early or late, just do a pregnancy test just to be sure. With the copper coil, it can sometimes be painful to have it fitted. Most people do find that it is at least uncomfortable, but generally just for a few seconds, but they might feel a bit sort of crampy and periody like afterwards. And then if they keep that for ongoing contraception, which is one of the good things about the copper coil, is that although it's fitted for emergency contraception, they can then use it for 5 or 10 years depending on what coil they've gone for. But they might find that their periods are a bit heavier, or they might last a bit longer, or they might be a bit more painful. If that is the case, they can always have it removed. But also it does tend to get better with time. So the first few periods will be a bit heavier or more painful, but it gets better. Or they could think about using some tranexamic acid or something while they're on their period. So it's not the end of the world.
Cool. And so you've got one coil, but there's 2 different oral options. What makes you choose one over the other?
So very helpfully, the Faculty of Sexual and Reproductive Health have got a lovely guideline on their website with an algorithm to help you decide. So if you're interested in looking at that, so it's the fsrh.org website, and if you look at the Emergency Contraception Guideline. But in general, ELA1, which is ulipristal acetate, that's most effective mid-cycle, because as I said, that works even after that LH surge has started. So if they're mid-cycle, go for that one. It's also more effective if it's been more than 72 hours. So between 72 and 120 hours, ELA1 is more effective than levonorgestrel. However, because ELA1 is an anti-progestogen, it means that if somebody's had any progestogens, so say they've been on the pill but they've missed some pills and that's why they're having emergency contraception, whatever hormones in their system from that could actually stop the ELA1 from working. So if somebody has had any progestogen in the last week, so if they've been on the pill or they've taken the other emergency pill within the last week, then you can't give ELA1 because they just cancel each other out. And similarly, that means that they can't start straight away on a new method of contraception after they have ELA1, because they would just cancel each other out. So the new method would stop the ELA1 from working, and the ELA1 would stop the new method from working. So if someone wants to start on contraception after ELA1, they need to wait for a week before they start on that. So you might want to, so if it's somebody early on in the cycle and they're wanting to start on the pill afterwards, then you might want to give them then levonorgestrel, because then they can just start straight away on their new method. The other things about ELA1 is that it's not suitable if somebody's got severe asthma and they're using glucocorticoids, and if they're breastfeeding, then they need to express and discard their milk for a whole week, which most people would not be very happy to do. So generally ELA1 is the first choice unless either they've had hormones, they're on steroids for asthma, or they're breastfeeding.
Excellent. Okay, so shall we go through some examples then? So almost like an OSCE scenario type thing. Okay. So you've got a lady who's come in who's not using contraception, and she had unprotected sex 2 days ago. What would you need to know?
Okay, so first of all, just make sure that she is actually at risk of pregnancy, so she's not been sterilised, or her partner's not been sterilised, she's not got a female partner, because that's always embarrassing if you start talking about emergency contraception because you've made an assumption that they've got a male partner. So check that first of all. Then you want to know when her last period was, and ask her if she knows about her cycle. So does she know how long her usual menstrual cycle is? Does she have one of those helpful apps or not?
Okay, so her last period was 7 days ago, and she's telling you that they come every 30 days like clockwork.
Excellent. So she's a very helpful patient because she knows what's going on. So she's day 7 of a 30-day cycle. So if we want to work out her expected date of ovulation, so we do 30 minus 14. So her expected date of ovulation would be day 16. So that means that she's eligible for all types of emergency contraception because she's not ovulated yet. So in terms of the copper coil, which is the most effective method, that could be fitted up to 5 days after ovulation, so it could be fitted up to day 21 for her. So actually she's got another 2 weeks to be able to get into a clinic and get a coil fitted. So just worthwhile remembering that it doesn't always have to be fitted immediately. So that would be the copper coil. Ella1 can be given up to 5 days after unprotected sex, and she's not yet ovulated, so that would also be fine for her. But if she wants to start on a new method of contraception that contains hormones, then she'd have to wait 5 days before she could start that. Or levonorgestrel she could have because she's pre-ovulation, she's within the time frame for that, and then she'd be able to start on a new method straight away. So she's in quite a good situation. She's come in nice and early, so she could have all the different options just depending on what might suit her best, really.
Time is on her side. Okay, so let's slightly change things around. So let's say she is day 18 of her 30-day cycle, and she's had unprotected sex every day, and she's already had the emergency pill 3 times this month.
Okay, so again, first of all, just think about whether or not she's eligible for a coil. Just your first line thinking when you think about emergency contraception. So she's day 18 of a 30-day cycle. So we've said that her earliest date of ovulation would have been day 16. So that means that she could have a copper coil fitted up until day 21. So she's got another 3 days to have that fitted, and that will be her 5 days after ovulation. And that would cover for all the sex that she's had that cycle, because although she's been having sex every single day, she can't have a fertilised egg until she's ovulated, and we're within 5 days of that, so we can fit that for her. The oral methods are going to be ineffective because she's already ovulated, so I would be advising her that her best choice is definitely a copper coil. No, yeah, so sometimes then people worry if people have been having sex all month that they might already be pregnant, but yeah, as I said, she can't be pregnant until 5 days after fertilisation, and if we know when she's ovulated, we can work that out.
Marvellous. And so we sometimes get patients coming to A&E asking for emergency contraception. We obviously don't provide emergency contraception from A&E. So where can patients access emergency contraception?
So they can get it from pharmacies. So some pharmacies will only be able to supply levonorgestrel, so Levonel, but some will be able to supply Ella1. They can get it from their GP. They can get it from any sexual health service. And the pharmacies that do provide it are also trained in knowing whether it's likely to be effective or not, and then signposting if somebody should have a copper coil. It's obviously only, well, you can't have a coil fitted in a pharmacy for a start.
I was going to say, I don't remember that bit of boots.
Not all GPs are able to fit coils either, so anybody who's giving out emergency contraception should be able to signpost as to where they can go. In general, in a sexual health service, we will fit somebody in that needs a coil, but come in as early as they can. Sometimes though, as we saw with that case, we might have even a couple of weeks to be able to fit it, but sometimes we have about 3 hours, so then we just do our very best.
Crack on.
Yes.
Brilliant. Anything else?
No, I think that's everything. Thank you.
Thank you so much, Katie. Bye-bye. That was the Take Orally Emergency Contraception podcast. Remember, you can subscribe to Take Orally on Apple Podcasts, Spotify, and SoundCloud. You can find the blog entry and the Take Visually for this podcast at takeorally.com. Take Visually is also available on Instagram. Remember, you can also find Take Orally on both Facebook and Twitter. For more information about research and education opportunities within emergency medicine, acute medicine, and major trauma, don't forget to check out NUH Dream on both Facebook and Twitter.